Well, hello everyone, and welcome to Johnny's Ambassadors Expert Webinar Series. I'm your host, Laura Stack, the founder and CEO of Johnny's Ambassadors Youth THC Prevention. We are here with a series of experts to help you understand the risks of cannabis use for young people. And today's webinar will be no different, whom I will introduce in just a moment. This session is being recorded. Those of you who are watching in person for credit, please make sure that you stay on until the very end of the webinar, as we cannot give partial credit. Robert will be giving his slide presentation for about 50 minutes or so, 55 minutes, at which point we will be doing some Q&A. So you have an opportunity to ask him questions. There is a chat box in the app. So as we go, please type your questions as you think of them, so that at the end, we will go in the order that they were received, and then we will do some Q&A. With that, I will take this introduction and move forward with our featured presenter. Dr. Robert Page is a professor in the departments of clinical pharmacy, medicine, and physical rehabilitative medicine at the University of Colorado Denver School of Pharmacy and Medicine. He is a clinical pharmacy specialist for the Division of Cardiology section of Advanced Heart Failure and Heart Transplantation. He's also the clinical director for the Colorado Evidence-Based Drug Utilization Program through the Colorado Department of Health, Financing, and Policy. He works closely with the American Heart Association in tackling this very important issue. And we are so happy to be bringing you the face of THC use, cannabis use, and the effects of cardiovascular issues on our youth. Ladies and gentlemen, I bring to you Dr. Robert Page. Robert, thank you so much for being one of Johnny's ambassadors.
Thank you so much. I'm very honored to be considered a Johnny's ambassador, and such a wonderful opportunity. And I'm very glad that everyone can attend today. Again, my name is Robert Page from the University of Colorado. Today we are going to be talking about a topic that we don't usually think gets tied into THC. Before we get started though, I do want to say that I have no disclosures with regards to this topic. I guess my only disclosure is the fact that I am a pharmacist. I'm not a psychiatrist, I'm not a physician, and I'm not a psychologist. However, I am a part of the healthcare team. And so you may be wondering, how the heck did a pharmacist get involved in this? So just a little bit of background of how I got into this space. I've been here at the University of Colorado now going on almost 30 years. I've seen a lot of evolution with regards to cannabis use. My training is in cardiovascular pharmacotherapy. Pretty much I focus in advanced heart failure as well as with regards to heart transplant. Because of that, being the pharmacist in this space here in Colorado, so in 2014, when cannabis became basically recreational and medical became legal, we had a lot of issues arise. Now, I do want to highlight the fact that you can't get a heart transplant if you're using cannabis. And unfortunately, I do have patients that are in their 20s and they are 25 or they're 18. They have congenital issues and now they have heart failure. But again, they're using cannabis. And so that has to be addressed. It is somewhat of a precaution contraindication for transplantation. Because someone does have to die in order to get that heart. So nonetheless, as we started to see issues arise, I became an expert within this field. And believe it or not, a lot of my medical colleagues then turned to say, what are you guys doing in Colorado? And so I've been very fortunate. I happen to be in the right place, in the right spot in order to really gain traction on this topic. in terms of research and publication and application into clinical practice. So I have to say, I've seen this cannabis when it was illegal, legal, and now really has integrated itself within today's culture. So and it's interesting because this is a part of medicine that many of my medical colleagues are not trained in. And also in this space, it is very multidisciplinary. And what I want to highlight is I rely very heavily upon my psychosocial colleagues with regards to psychiatry, with regards to my psychologists and my social workers. It's really a nice integral part. But nonetheless, today what I wanted to share with you again is not only some of my experiences within this space, but also some of the literature that's out there. Now, I realize we have probably some variations in medical training. So I'm going to talk sometimes a little high level, but I've always kind of bring this back down to make sure that everyone understands what I'm talking about. And if I mention something you don't understand it, by all means, please send your question in. So as you can well aware, not everyone here is in Colorado, but our landscape has really changed. It's gone from being completely, I mean, again, I grew up in the 60s and 70s. I was a part of the growing up of the war on drugs, and this is your brain on drugs, and this, that, and the other. So we went from really, this is very, very bad, to now we have a dispensary on almost sometimes every corner. And so things have really changed in terms of the climate and also the social acceptability with regards to THC. So what I'm going to talk about is kind of what we know and also what we don't know. First and foremost, there has been a huge, as I mentioned, a huge change in societal perception. Again, I grew up with Saturday morning cartoons of where this is your brain. They would crack the egg to now, again, this is integrated into a lot of medical school teaching, pharmacology, this, that, and the other. But what you're seeing here is, again, the change in the U.S. Cannabis market. Now, these are a little bit older data. We're always about a year behind. But as you can see, that in 2025 compared to 2016, we've seen almost a 5 to 7-fold increase in not only recreational use, but also what we would consider medical use as well. When I refer to medical use, that refers to every state has their own laws that are surrounding this. And there are certain conditions here within the state that you can obtain what I call a green card in order to obtain higher potency THC. Things such as, again, with regards to movement disorders, from PTSD, but it varies, all of these vary based upon state legislation. And so the other show of in terms of change in perception is with regards to, if you look at, I mean, I was thinking about this as I was driving in today. You know, I only pass, coming from my house all the way here to the university, I pass about 3 Starbucks, but I pass a total of 15 different dispensaries on my way in. And so this just shows you Portland, Denver, Seattle, and Anchorage. You can see here that per capita, we have more retail marijuana stores than we do, or cannabis stores than we do dispensaries, compared to that of Starbucks or even that of McDonald's. Why do I bring that up? Well, if you look at the scientific data with young adults, availability is a key. If it's something that's more available and we have more access to it, we are going to have an increased use. So if you have a cannabis dispensary on your corner, you're 3-fold more likely to use a product if it's available. And in today's society, particularly here in Colorado, this is very, very prevalent. The other aspect is that this is not federal law. By federal law, there's been some debate over the last 5 years about making cannabis, changing it from a Schedule 1, where there are actually no medical indications, and has a very high addictive potential, to that of a Schedule 3. This has been tossed around, gosh, with the federal government for many years. I know it was to be evaluated under the Biden administration. I think it kind of got lost under the new administration, but it'll be interesting to see. Nonetheless, everything is regulated currently at the state-based level. And what your map is, and the link that's attached to this at the bottom, the disa.com link, is probably by far one of the best websites that I'm aware of that keeps up to date on state and cannabis laws. So if you're out of Colorado, you can click on that. It'll explain in extreme detail exactly the laws that do or don't exist. But as you can see, this map is actually relevant as of today. You can see here which states cannabis has been fully legalized, whether it's medical or decriminalized, whether it only is legal for medical, whether it's decriminalized, whether it's CBD or THC only, and then again, what's in orange is fully illegal. I always say, and I crack this joke just because I'm from South Carolina. I'm a Charleston guy, and I always say that when South Carolina makes cannabis medical or recreational fully legal, I think hell has frozen over. But anyway, nonetheless, you can see there are only about 4 states where it is still truly illegal to obtain cannabis. The other reason why I bring this up is the fact that in terms of transporting across state lines. Remember that it is illegal to transport cannabis across state lines, and regardless if you're driving, flying, etc. So I always remind people that as well. And again, individuals are bound by their state laws with regards to, if like in terms of work requirements and those type of things. But from the map, you can see our policy evolution. It's becoming very, very green. And I only guesstimate that over the next 5 years, things will continue to get greener. The other issue that comes up is with regards to, and I love this slide just because it just shows this is an older study. And believe it or not, I saw some of this Pew Research Center report reevaluated, and it still stays the same, that only 10% of older adults really say that cannabis should not be legal. The majority of today's society here in the States believe that it should be either for medical, recreational, or both, but that it's something that should really still be considered legal in terms of its use. And what's interesting is if you look at the politics, the background, socioeconomic determinants of individuals who responded to this, you can see here that it doesn't matter if you're Black, white, Asian, Hispanic, how old you are, if you're Republican, Democrat, whether you lean one way or the other. It doesn't matter. Less than 15% across the board think that this should be illegal. For the most part, many individuals have accepted this. So this is going to be an issue. This is going to be like tobacco and alcohol. It's going to be a part of our society going forward. So understanding the potential dangers that can go along with it, I think, is quite important. Now, one of the big issues that has arisen over the years since legalization, particularly in our state, is we've seen the emergence of what I call second-generation cannabis products. That's what you find in dispensaries. Typically, what has been studied up into about, I would say up to about 2000, has really been first-generation cannabis products. So that's been something people have grown or gotten on the black or gray market. And again, why I bring this up is the variation in THC. Because I teach this at the medical school and here at the pharmacy school, I treat these like over-the-counter medicines. I've actually gone into dispensaries and I toured these dispensaries, and it's quite interesting, this whole this whole business aspect of it. But more importantly, now growers have a way of actually breeding plants that actually will synthesize higher quantities of THC, or what I call second generation products. And as you can see here in this slide, this is really from the DEA. This is really from 2095 to 2019, and that these lines continue just to go up. What you see here is in red is THC content compared to CBD content. Now, if cannabis does have, if it did have any really big therapeutic benefits, it would be more from the potential of the CBD than it would be the THC. THC is probably what's most likely driving a lot of the cardiovascular side effects that we see. But CBD is believed in animal models and in other in vitro models that it can be anti-inflammatory. But in terms of synthesizing, it's actually more expensive to synthesize CBD than it is THC. So believe it or not, we've seen a drop in products that have CBD, and we've seen a dramatic increase in the amount of THC, or the lucitropic effects that we see from cannabis. And again, that has been one of the issues that has arisen, because we're seeing a huge increase, not only in terms of cardiovascular events, but also in terms of other aspects. But the key may lie within, is it related to these very high potency THC products? Now, I know I have individuals on the line that are maybe parents. You may not be familiar with the lingo, but there are many different formulations that exist. And you may ask, why do I bring this up? Well, when you're a parent, you want to understand what your child's talking about, or, you know, when they drop these two. So this is basically just a little bit of a summary of some of the common formulations that exist, and then also how they're administered. For the most part, these cannabis can be either vaped, it can be smoked, it can be given as an edible, it can also be given rectally, sublingually, in many different forms. What's the most common that you will see sold are the resins, or the keef, which is highly concentrated forms of THC in very small amounts. The same thing can be in the form of things such as wax and shatter, and again, these are like rosins. Most of these types of products you'll see mostly in terms of vaping. And again, if you see the product, you actually will see, again, it's remember, cannabis is very lipid, or very fat soluble. It's very sticky. And so therefore, in order for it to be dissolved, it has to be dissolved with another fat soluble substance, so that it can then be either combusted or, again, consumed. Now, when you're thinking of cannabis, you can think of first and second generation, but you can also think of what we call phytochemical or phyto products, which are derived directly from the plant itself. And then you have synthetic products. Now, synthetic are what is derived within the lab by medicinal chemists. And believe it or not, I've actually interacted with some of these individuals to see how they prepare synthetic THC and this, that, and the other. And then when you have the synthetic cannabinoids, you also then can break it down further. You have what we call prescription, and then you have your illegal. Now, what I'm talking about prescription is THC and CBD have been utilized in some prescription medicines for many years. And what you see on this slide in this yellow box, the most common right now is actually Epidiolex. Epidiolex, it's a prescription, is actually more phyto-based. It's derived directly from the cannabis plant. The medicine that here in the United States that I've used throughout my career is Marinol or Dronabinol, which is a synthetic form of THC that we use for appetite stimulation and things such as nausea and vomiting. Sesamet and Sativex are found outside of the United States, but they are also used very similarly in terms of for nausea, vomiting, as well as for appetite stimulation. Epidiolex has an indication primarily for Dravet syndrome and other complex treated seizures that are really intractable within children and young adults, with some pretty excellent data. Then you have your synthetic illegal forms of cannabinoids, and these are things such as K2 and spice. There are a few more that have emerged onto the market. These are several-fold more potent than your typical THC. And so therefore carry with it, and I'll show you, a very large amount of cardiovascular side effects with regards to this. Now, again, I bring up all these formulations just to make sure we're all on the same playing field, but how are individuals utilizing this within today? And this was some of the most recent data. And this came out of the Centers for Disease Control and just recently published in MMWR. And what this was looking at is how many different routes do individuals use. Now, this is a survey called Behavioral Risk Factors Surveillance System, and it consists of 22 states, 2 other U.S. territories, and these are data from 2022, so they're fairly recent. We have about 5,000 patients, or 5,000 survey individuals who were surveyed. Now, these are primarily going to be young adults. And as you can see here, believe it or not, the majority of individuals who were surveyed who were using cannabis were primarily either smoking or eating it. And again, it's very similar to smoking, and also not only smoking it, but vaping it. And I'm going to highlight why that particular combination is very, very bad in just a second. You'll also notice that in here that a smaller amount are doing the dabbing and vaping in combination as well. So again, individuals are using a variety of methods for administration, and that is very important when you're looking at adverse drug events from a pharmacoepidemiologic standpoint. Because remember, and I'm going to talk about this right now, is the fact that how the drug is administered, it really impacts the onset as well as the offset. Now, why is that important? Well, realize that when you use cannabis, you are interrupting your homeostasis process that's going on in your body, and I'll go over this in just a second. But if you do it too acutely, the body can't respond in order to equilibrate itself, if that makes sense. And that's why when you're using a substance that has a quick onset, it can have very rapid effects, like a stroke or a heart attack, those type of things. And so if it has a more slower onset, it gives the body time to fix the process in order to, again, re-equilibrate blood pressure, reset, again, heart rate, these kind of things. So onset and offset are very, very important. When it comes to administration, the onset and offset that is the most rapid and most documented is when cannabis is either vaporized or smoked. The onset is within minutes, 15 to 30 minutes, and the offset, the effects can last for about 1 to 2 hours, but also within that time period, you can get a slow offset. Believe it or not, when individuals are using, in terms of cannabis for nausea and chemotherapy, a lot of individuals like to use vaping or smoking, even though it is really, really bad on other organ systems, but it's easily titrated. It's almost like an intravenous infusion, and you see the effects, and you can titrate the effects very easily. So that's one aspect, but we're now seeing damage occurring also now within the lungs. In terms of we now realize, if you're using it orally or you're using it subcutaneously or buccally, there's a 3-fold increased risk for now oral cancers that we're starting to see. There's a lot of issues that go along with that. In terms of the most erratic absorption, that is what we see with regards to the gut or, again, oral ingestion. With oral ingestion, realize that it poses more of a risk for long-term effects, such as drug-drug interactions, because this has to go through the liver to be metabolized. And that in of itself creates its own issues. But the second thing is that the onset is highly, 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 highly variable. The onset can be it can be 30 minutes, but it can be up to like 2 to 3 hours. It can be hours. And then you don't know how long it's going to stick around within your body. Remember, this is cannabis, the THC and the CBD, these cannabinoids are basically very fat soluble. So it can distribute very much throughout your body and remain in those stores for many days to weeks, and then slowly leach out. To show you an example of a medication, I call it a medication mishap, but I remember reading in the New York Times in 2014 when, again, our dispensaries were legal here in Colorado. And so a young reporter came down here from New York and went into one of our dispensaries and bought a bunch of cookies. Well, then she went back to her hotel room, and no one explained to her any of the what to expect, the onset, and what did she do? She ended up eating half of a cookie, waiting 30 minutes, not seeing any effect, and then she dose dumped. She kept eating until she saw an effect. And the problem is that accumulation effect. Cannabis has what we call zero order kinetics, meaning as you increase the amount you're taking in, it doesn't just increase in your bloodstream incrementally. There comes a saturation point where you saturate your liver, and then boop, the levels go skyrocketing through your system. And that's exactly what happened. And she developed significant psychosis, paranoia, and had to go to Denver Health because literally she became psychotic. So just to show you what can happen without understanding the pharmacokinetics of cannabis and some of the medication misadventures that can occur. Now, one of the applications that's really being studied currently right now is really topical. And what's interesting is I can say anecdotally that, we do urine drug screens on all of our patients who are admitted into the hospital on our cardiology service, but also if they're being evaluated for a heart transplant or any transplant for that matter. And I can tell you that I've seen individuals who've used topical CBD THC, and they don't show a positive urine drug screen. And I believe the fact is because this is very fat soluble, it stays in the epidermis or the dermis and slowly leaches over time. So again, the problem with this is we don't really have any data on its onset, offset, or really any data with regards to efficacy. But I can tell you that I've seen less adverse events with the topical preparations when individuals are using a cannabis product for pain or for inflammation. One of the things, again, as you've heard me toss this term around, but the active ingredients in cannabis are cannabinoids. You have THC and you have CBD. Those are your most common. The one thing that I do want to highlight is that, I have patients that will come up and say, well, you know what, Robert, I've been using a CBD only product. And then I always ask, well, where'd you buy it? And they said, well, I bought it at Whole Foods. And I said, I'm going to let you know right now that if this is a true cannabinoid product, it will always have THC. There's no way to eliminate the THC from the CBD when it's being derived directly from the plant. You will always have some residual THC that's always within that. So for example, I had a patient of mine that went for massage therapy, and basically they said, yes, they offered me to use CBD oil for relaxation. And I said, this was a pharmacist, so I'm like, she knew. She goes, well, this isn't psychoactive, it shouldn't be an issue. But when she left, she was completely gorked out. And the reason being is the application of this was total body. And so this also shows you that when you're using it for a small amount in a small area, your absorption is relatively, but if it goes total body, there is going to be some THC in that product, and it is going to affect your demeanor. And that's why I'm like, you needed to call me. I would have picked you up and taken you home. She goes, I had to take an Uber home. So I'm just warning you that these products are not 100% safe. The reason you can find these products in places like Whole Foods and the availability of it is because of the Hemp Act that was passed, a couple of years back. And what it did is it defined hemp as anything that has less than a certain percentage of THC in it. I will say I just read last week that I think the Trump administration has eliminated that. So we may see some products coming off of the market because of that. But nonetheless, that's the reason why young adults, teenagers can buy this stuff within Whole Foods or with the grocery stores or even pharmacies. Why is vaping so bad? You know, vaping really got a lot of bad press. Initially, it was being sold as that we can use this to wean off people from smoking, this, that, and the other. But we now realize that vaping in and of itself is just as bad as cigarette smoking. And it was just prior to COVID, there was a large number of individuals that developed what are called e-cigarette or vaping use associated lung injury, in which these individuals had to be evaluated for lung transplants. Like their lungs were shot because they had been vaping. And when the CDC went in to look at this, they basically found that the majority of vaping products where this was occurring were THC based. Well, remember, I mentioned to you that THC is very fatty, and so it's very sticky, and it's like a resin. So in order for it to be solubilized, so it can be either combusted or smoked, you have to mix it with another fat-soluble substance. And what many companies were doing is they were mixing it with vitamin E. The problem is that vitamin E, when you inhale it, it's fatty. It gets into the bronchioles of the lungs, and it just sits there, and it stimulates an immune reaction because the body says, this is not me, and there's no way to break it down because it's all fatty. And so therefore your body starts attacking the tissue, and that's where all this lung issues were coming involved. Now, a lot of products will tell you now we don't use vitamin E, but that I still see this within products, and I warn young adults not to vape because this can lead to longer term lung issues. The other is, if you look at this figure on the far right, you'll notice that even after the cannabis has undergone combustion and inhaled in terms of the primary smoke, what is then exhaled, that aerosol actually contains very toxic components, things such as acrylide, copper, nickel, propylene oxide, all of these, formaldehyde, all of these things are very cancerous and also have a large amount of cardiovascular toxicities associated with them, such as like cell death and those type of things. And so just by heating that for these products and creating this additional secondhand smoke is an issue. One of the things I'm trying to propose to the American Heart Association is we need to evaluate the impact that secondhand smoke from cannabis, either vaping it or combusting it has on, an example, pregnant women who are pregnant, children who are in closed areas. You do absorb this, and so this becomes a huge issue. Here in Denver, we have cannabis clubs, and it's pervasive. You can smell it everywhere. And so the question is, that by smelling this stuff, am I putting myself at risk? And these data are slowly emerging to be the answer is most likely yes. When we do talk about cannabinoids, there are, the ones that we talk about are things such as the delta-9 THC. We now have delta-8 THC as well, the synthetic form, cannabidiol, but we also have CBN, CBG, CBE. All of these are being explored as therapeutic targets. But I do want to highlight the fact that we really just don't know. There are like several hundred cannabinoids in these plants, and we haven't really teased out all of them and know the impacts that they have. But these are also being studied as therapeutic targets. Now you may say, now we're going to kind of start moving into the cardiovascular aspect, but you may say, how do we know so much about all of this? Well, believe it or not, your body has in it, it's called the endocannabinoid system, endogenous cannabinoids. 2-arachidonyl glycerol is the one that's most commonly produced by your body. Your body has two types of cannabinoid receptors in it. It has CBD1 and CBD2. Your body produces an anandamide and 2-arachidonyl glycerol, actually in order to modulate your just general homeostasis. What that means is just maintenance and the running of your body. It's a mechanism that your body uses. But we know that by binding, when these substances bind to certain receptors, they have certain effects. Now, your CBD1 receptors are found across the entire body, within the central nervous system, the skin, the liver, the adipose, skeletal muscle tissue, all of this, but also it's found in the cardiovascular, or excuse me, within the cardiovascular system, particularly within the heart and also within the vasculature as well. CBD2 receptors, on the other hand, are primarily found on inflammatory tissues. Those are things like white blood cells, immune cells, peripheral immune cells that are responsible for stimulating substances that are very pro-inflammatory, called cytokines. So it actually inhibits some of these as well. So understanding this is actually how we have understood the potential impact that exogenous cannabinoids have on our body, okay? Now, outside of these receptors, and I apologize, this is a lot of, maybe a little bit higher level, but there are what we call off-target non-cannabinoid targets that CBD and THC may have an effect. The ones that I want to just really kind of highlight are the ones, these what we call G protein coupled receptors. This is really affects things like dopamine and norepinephrine and adrenaline and serotonin. We know that THC and CBD have effects on these, okay? That's one. The other is they can affect certain ion channels. Now, ion channels, when I talk about ions, I'm talking about calcium, potassium, and sodium. These are very, very important ions that are responsible for myocardial contraction and relaxation. And we know that CBD and THC can interfere with these, which leads to potential issues. The other is the effects, this peroxisomal proliferator activated receptors. They're called PPAR, alpha, and gamma. Believe it or not, this may actually be a beneficial effect, that these are anti-inflammatory. But this is, one of the misconceptions is that individuals who do use cannabis continuously, that they probably have a metabolic milieu, or what I mean, like bad cholesterol, bad triglycerides, eating all the time, not exercise, blah, blah. Believe it or not, that's not the case at all. They actually have, and it's because of this PPAR alpha and gamma, it has this effect that may have beneficial anti-inflammatory effects to keep glucoses down. And so therefore we don't see the badness with bad cholesterol and those kind of things as well. But let's look, again, the topic of this is really in terms of cannabis use. So now we're in cannabis use in adolescents. So now let's get a little bit more focused. Now we've gone over the background and some of the pharmacology. So what is, in terms of adolescents, what these data are, these recently were published from the Substance Abuse and Mental Health Service Administration, SAMHSA, which I've used a lot of their data, and they're, again, excellent federal data. But what this is looking at is cannabis use among people age 12 or older between 2021 and 2024. And on the left, you'll see this base stratified by age. What is positive right now is the fact that between the ages of 12 to 17 and 18 to 25, we've had a level off of use when you compare 2020, 23, 2020, 25, 2020, 24. I've seen the 2025 data, and it's stayed relatively stable. Where we have seen a slight uptake, however, has been in what's scary is in our over 12 and older, the overall population, as well as those of young adults of 26 and older. So while we've seen some age groups level off, here we've seen this slight increase as well. And again, these are some more data, particularly targeting young adults, stratified at the bottom based upon age, using cannabis in the past month. This is looking at marijuana cannabis use, but not vaping, or what's in blue is just vaping. And as you can see, really for the populations that I worry the most about, between 12 to 25, it really seems to be a vaping issue, which has a double-edged sword, because there are other issues outside of just the THC and the CBD effects, but all of these nasty chemicals that are involved in combustion that are causing issues as well. As we get older, 26 or older, we find that it's more going to be edibles as well as mostly smoking. Now, I would be remiss if I did not highlight one of the most important aspects that worries me the most with regards to adolescent use, and I know everyone has been probably familiar with this, and this is in terms of CUD, or cannabis use disorder. When patients are admitted for myocardial infarction and come onto my service, regardless of age, I do assess them for cannabis use. And if they are using it on a regular basis, we will reach out to our social worker to do an official social worker or psychologist to do an official CUD workup. These are the risk factors that exist for with regards to developing CUD and cannabis use. There are some early predictors, childhood adversity in terms of social determinants of health, early exposure to tobacco and alcohol, perinatal exposure has also been. But also there's some ones we don't really know the impact, as I've highlighted. Number one is high potency products and the synthetic THC analogs that you're seeing enter onto the market. And also overall patterns of use. Is it daily? Is it once a week? Is, et cetera. When you combine these factors in a young adult, you can see here, this what's at the bottom is 13, all the ages, all the way up to 25. You can see right there when you hit that 16 to 17, we find that it's going to basically be more males than females. The more that you use at a younger age, the more likely you will develop CUD. If you have some underlying psychiatric issues, depression, bipolar, anxiety, and this all starts to spike around the age of 16, 17, 18. We also see emotional stress and dysregulation. We also have your own physiologic cortical thinning. You can see also increases with age. All of these kind of combine in order to see this potential development. And that's something I think we should really be evaluating as well. Now, when we get specifically to cardiovascular risks, I mentioned before, you have THC and CBD. In terms of the cardiovascular effects, it depends on what receptor we're binding to. In terms of THC, it binds solely to the CBD1 receptor. And that receptor in the heart can have an effect at the level of the neuron, at the level of the myocyte, along the endothelium that's lining your coronary arteries and your vasculature, as well as fibroblasts and microblasts, which I won't go into. CBD, on the other hand, while I want to say it is absolutely not an innocent bystander, because while it affects the CBD2 receptor, which is very anti-inflammatory, it does still have effects upon the CBD1. All the negative things that we see cardiovascular-wise are derived from that CBD1 receptor. So both THC and CBD play a role. So when you're using a combination product, you are hitting it at each one of those levels. By having an effect at the neuron, we're enhancing your fight or flight. We're causing the surge of catecholamines. That means it increases your heart rate. It increases your metabolic demand. It increases your blood pressure. All of this puts a lot of stress on the myocardium, and that can lead to things such as myocardial infarction or even cardiac death. And in some cases, if you're getting too much vasoconstriction and not perfusing the brain, you can lead to what we call a stroke or a cerebral vascular accident. This slide kind of shows what's been reported in the literature. This was from a paper I did for the British Medical Journal a while back. And it just really highlights the facts that there are a multitude of cardiovascular issues. What we're seeing mostly in young adults is primarily that of stroke. And I can comment on this anecdotally. We're actually seeing an increase in the amount of acute stroke, arrhythmia with stroke. I've had about 3 patients with what we call ischemic arteritis, which is where you get the arteries within the lower extremities get very, very much inflamed. It's very similar to a medical condition called Bircher syndrome, but I did have one patient who came in and we could not understand why he was having ischemic arteritis. And I asked him, I go, well, what do you do for a living? And he goes, I am a bud tender at a dispensary. And I go, do you wear gloves? And he goes, no. So he's been absorbing all of this through his hands as he's dealing with buds and with cannabis buds, and it's now he has something like peripheral artery disease. So again, we set up some precautions in order to treat that. He is also now on an anticoagulant in order to prevent him from having further damage. But the one thing I do want to highlight, a large number of these data are derived primarily from the synthetic cannabinoids, and that's what you're seeing here on the right. Just to let you know, there are a lot of medicinal chemists out there making some interesting compounds with THC, and believe it or not, they're highly potent, and they have translated into more issues on the cardiovascular system. One of the big problems that exist when you're dealing with major adverse cardiovascular events is you really would like to have prospective studies, particularly randomized studies. Well, you're not going to have that when it comes to cannabis research, at least at this point, because it's a Schedule I product, meaning it's very difficult to get this through an IRB. It's very difficult to obtain. We can only obtain it from certain facilities. I have several colleagues that are doing studies with this, with PTSD and some other psychiatric illnesses at the VA. But most of these data are going to be observational. And just the bottom line on observational data, where we just observe people who are using it, is because it's not controlled. I cannot conclusively say that this is a causation, that cannabis causes this. I can basically say as an epidemiologist that it is as an association, but that does not mean we say, oh, it's natural, it's safe, we're going to not worry. No. Anytime I see something reported, it's a red flag. It is a safety signal and should be taken with that level of respect. So the data I'm going to show you in young adults is pretty alarming. But again, it is retrospective, so these are associations. I can't say 100% it's causation. One of the things, this was a nice study that was done out of the VA a few years ago, and this was looking at young vets. They were both male and female, but these were young adults. They stratified patients based on females and males. They had over 18,000 females, and males, they had about, again, 116,000 individuals. These were individuals who were also using either single or multiple substances. And what the investigators did is they looked to see in these young adults their development for what we call ASCVD disease. That's atherosclerotic coronary vascular disease. I want you to think of this. The end game for that is having a big old myocardial infarction, and that leads to other issues like heart failure and those type of things. What we saw, if you look here in the middle with cannabis use, is that young women who were regularly using cannabis had about a 5-fold increase, and men about a 2.65 increase in the development of early ASCVD disease. That means that when we looked at them, looked at their catheterizations, they were prone to having a myocardial infarction. And this is pretty alarming because most young adults do not think that they're going to have a condition that they would develop it when they're 60 or 70. Again, I see it now in the 20s and 30s, believe it or not, heart attacks that can be associated with cannabis use. And believe it or not, I agree with these investigators that it is a new risk factor, just like smoking, no exercise. I treat cannabis use, particularly smoking, as a risk factor for developing coronary artery disease, as well as having a myocardial infarction. And in fact, the number of recreational substances that are used as you stack them on from 1, 2, 3, or 4 or more, you can see that the risk from one agent, again, is 2-fold. When you get up to 4 or more, it's almost 8-fold. So that is a huge, huge consideration. I hate to say this, but young adults mostly are not just using one substance. They may be using multiple substances, and this increases their risk for having a heart attack or a stroke. I'm going to skip through this one here because I want to show these data right here. This was a Canadian study, believe it or not, and Canada has some very good, robust data because, again, everything has been legal, both recreational and medicinal. And what these investigators were doing is they were looking at the risk for fully development of a myocardial infarction in very young adults who were using cannabis. They were either smoking it, vaping it, or eating it. And again, they also looked at frequency of use. So we found, even though it wasn't statistically significant, and I'm going to show you some data that also corroborates this, but the more frequently you are using cannabis on a daily basis, the more likely you have a twofold increased risk for having an event. The other is, and this was, again, statistically significant, what we found is smoking really is probably has a much greater, more statistically significant impact than edibles. Again, this is an association, and I believe it's because when you smoke, the onset of the effects are really quick in your brain, your heart, nothing, you cannot equilibrate, you can't equilibrate quick enough, and that's why you end up having these bad effects. Now, one of the issues that I've heard in young adults is they go, well, Robert, you know what? I'm not smoking cigarettes. I'm only smoking cannabis or vaping it, and it's natural, so it has to be safe, right? And the answer is absolutely not. And these are data that was published from one of the American Heart Association journals. I know there's a lot of numbers and stuff, so I'm just going to summarize this for you. If you look at the top, what these individuals did is they used, now this is survey data and observational data, but these investigators actually looked at several thousand patients, and they looked at their development over time for coronary heart disease, myocardial infarction, stroke, or the composite of all of these. And so if you were a cannabis user, you had a 1.5-fold increased risk, almost a twofold increased risk for developing a heart attack. Again, stroke, twofold. The composite of all of this, almost 1.78-fold. Now, the coronary heart disease was lower, and the reason for that, I believe, is because coronary heart disease takes a little bit longer in order to see an effect. In terms of events, you can have an MI or stroke in an acute situation, and that's kind of what I've been seeing within clinical practice. But these investigators also took it another step. They looked at days of use and also the development for coronary heart disease, MI, stroke, or the composite. And what you see here is if you're using daily for 5 or more days, there is an incremental increase in the development of having a stroke or a heart attack. Now, those are very devastating, and young adults have no clue. I took care of my mother until she passed, God rest her soul, from a stroke, and I will tell you that was the most debilitating thing. Now, it wasn't related to cannabis, it was from cigarette smoking, but one of the big issues is that it is very debilitating. And when I explain this to young adults, they go, I do not want to have to deal with this. I do not want this. So these data are very powerful when I'm talking to young adults. The other issue that comes up, and I know this is a little bit of slide, but these are some newer, much newer data looking at arrhythmias. I've also seen this. When I'm talking about arrhythmias, I'm looking at atrial arrhythmias like atrial fibrillation, but I'm also looking at ventricular arrhythmias as well. And what these investigators did, this was an observational, again, study, retrospective, and again, you can see here the median age. These were not really young adults, but they had a median age of around 60. I will say these same investigators did another similar analysis within young adults, and very similar. And what they found was a statistically significant increase in the development of atrial fibrillation. What these data here also show from the plot that's over here on the far right is the fact it didn't matter whether or not they were utilizing a CBD product, a CBD or THC, or just a pure THC product. Any of these kind of arrhythmias actually developed regardless of the product. And also whether you were young, old, it didn't matter. But this has also been reported in the literature as another big issue, having a sudden ventricular arrhythmia that can be fatal, or it could be atrial fibrillation, which you can detect. It feels like your heart's pounding out of your body. And this can be even more exacerbated when combining it with other stimulants like caffeine, that comes from coffee, tea, etc., those kind of things. So in young adults, we're seeing these type of events, particularly with cannabis use, but also with those who are smoking. So what do we don't know? Well, what we don't know, and it's kind of evolving, is with regards to first versus second generation. It's looking like at this point, the observational data are showing that these new second generation products, this is why we're seeing a huge increase with regards to cardiovascular events like heart attacks, strokes, arrhythmias within younger adult populations. And it's primarily with the second generation than the first generation. Is there a relationship with chronicity of use? The data is starting to say yes. Daily use, any use is not good, but daily use has definitely been associated with an incremental increase for the risk of having these events. So the answer to this is starting to be yes. Is there a dose-response relationship? Absolutely. The observational data is teasing out that it is. Now, whether the cardiovascular side effects are more pronounced with edibles, smoking, or topical, we don't know. I will say, Dr. I'm going to call him out. Dr. Stringer out of the University of California in San Francisco does probably the most robust research with looking at the actual cardiovascular particular mechanism of why it's so bad, and particularly with smoking and the effects of secondhand smoke. And out of his lab, he really found that we think, regardless of the formulation, it has something to do with nitric oxide at the endothelial level. Nitric oxide is very protective. For those of you without a medical background, I want you to think nitric oxide is a good thing. When it's low, it can be a bad thing. And so that could be one of the things that's coming into play. But we think that regardless of the formulation, the effect is at the endothelial level and at the level of the myocyte. Is this a risk factor for ASCVD and stroke? Absolutely. This is one of the reasons why my institution, I had pushed for universal drug screening, not just for illegal, but primarily for cannabis, so that we're actually able to quantify it and use it as a risk factor for developing ASCVD and stroke. And then, could CBD be beneficial? Well, it could be. I think in terms of it being an antioxidant, absolutely. But you forget, CBD has an effect upon the CBD1 receptor, so it will have cardiovascular side effects. So CBD is not an innocent bystander. It is it is an active participant in some of these events. What do I tell when I get a 21-year-old who is admitted for a heart attack and we find out they're using cannabis? What do I tell these patients? I'm like, you think you're invincible. But believe it or not, again, you're developing conditions that we would normally see 20 to 30 years later. And again, we're beginning to associate this with the use of cannabis. And again, the other thing I always tell young adults is realize your cortical, your decision making isn't really formulated until you're about the age of 26, your cortical part of your brain. So it's hard to make these decisions. And so having these decisions should not be rushed. They should be very thoughtful. They should be non-judgmental, but knowing these risks. I have individuals that I get called up by sometimes young adults, and they're like, you don't know what you're talking about, and blah, 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 about cannabis. And I'm like, look, I'm not here to judge you, and I'm not here to tell you what to do per se. That's up to you. I'm here to educate you to make an informed decision with your caregivers and with your medical providers, an informed decision. And ultimately, whatever decision you make could have health consequences. And when I frame it like this, it brings the conversation back to them. And they go, wow, you're not judging me. I'm just sitting here trying to give you my opinion. So again, this is a very tough conversation to have, but very, very, very important, because again, this particular generation, they do not want to think of long-term consequences or in those things. So the next thing I've been coming up with is coming to a dispensary near you is with regards to our psychedelics. This is something emerging here in Colorado, and we're beginning to see some cardiovascular issues, but that's another topic for another day and another story. But at this point, I do want to thank Johnny's ambassadors for this amazing opportunity. I think we hit it right at the top of the hour.
Yes.
Yes, and at this point, I would be more than happy to answer any questions that you might have. And hopefully this has been informative. You can take this back and utilize it. Again, I'm here at the university. You can always reach out to, again, us here at the university. I'm always answering questions from the public on this topic.
Thank you so much. Robert, you are just delightful. You're the kind of guy I'd love to sit down with at lunch, and we would probably be there for 4 hours just Shed
As
it
I said,
away.
the only thing I always highlight is I am a pharmacist. I am not a psychologist or a psychiatrist or a social worker. But I will tell you this: over I would say over the last 15 years I've been doing this, I have developed the closest relationships with them, and we have developed some fabulous policies working one-on-one. I will say, in this space with cannabis, it is a multidisciplinary approach.
Oh my
And not
gosh,
just
it
medical
takes
professionals,
a
but
village.
it
Yes, a
does,
whole army.
the parents and siblings and all, it needs to be, yeah.
Well, this topic is vitally important because I see in the high schools, the middle schools where we do assemblies about 200 a year. You know, that's one of the things I'll get a line afterward and they'll say, you know, it's medical, it's good for you, you know, and as much as you try to explain, it's bad for your heart, it's bad for your lungs. You know, having this recording and to be able to show them, like you said, the facts, they appreciate that. They want to know.
This
Tell me
generation, I will say, they want you, they don't like, I don't blame them, they don't want to be told, but you need to give them the information. You need to give them the information that everyone needs to make an
they
informed
like
consent.
data, they like research. I think this is a great approach. And it's not just, you know, but it's also you're explaining the endocannabinoid system, you know, the receptors, they can handle this kind of information. You know, we talk, it's our assemblies are very science-based, and everybody's surprised. And it's like, look, when does preaching work? You know, don't do drugs. Drugs are bad. You know, they don't.
In the 70s and 80s, I will say that. So I'm just saying, it needs to. This conversation has to be had. The unfortunate thing is,
so
a lot of young adults don't see their primary care provider or don't have a primary provider. And see, that's something else I try to get people to do, because then you can have this conversation. So.
Well, we did get one question, and then we will let you go. Actually, we just got another one. This says, this was so informative, incredibly alarming. I will be sharing this with our youth and the young adults that I encounter in my mental health setting. So that is a thank you to you. And then the other question that I got was related to apparently a rumor that is heard today that the Department of Justice / Trump administration will be rescheduling apparently Monday from a 1 to a 3.
There you go.
So you were right on with, you know, we're hearing this.
So
and what does, the question is, what will this do in the way of perception for young people? If you could frame it in that way, what will this do in the way of perception to young people, and why could scheduling from 1 to 3 be a public health concern for, say, a high schooler or a college student? How would you respond to that question?
All righty, so I'm going to talk about it from the standpoint of the dispensary. Then I'm going to talk about it from the standpoint really quickly on research. And then I'm going to talk about it at the level, what does this mean for young adults and patients? So, and what I would say. So first of all, what this will do first, and this can be a bad thing, is that you're going to see now if it becomes a Schedule 3, then there are certain tax exempt aspects that can be applied to with dispensaries. So you could see a burst. Right now, what happened is we saw a huge explosion of dispensaries in neighborhoods and all of this, that, and the other in the beginning. And people then began to realize with taxes and stuff like that, it's not going to be it's a bust. More, it's not the boom, it's going to be a bust. But this could flip it, because there will be some tax exemptions that go along into that. The thing will be is if it's considered to be a Schedule 3, it's a drug. I don't know what this is going to impact, but that means a pharmacist or a physician has to dispense it. So
meaning the raw cannabis, like flower?
Yep. That means it's a Schedule 3.
Which has never been proven to be medicine. There are, as you said, 100 or plus cannabinoids in raw flower, and only in THC, CBD are FDA approved cannabinoids. So how can a pharmacist medically, ethically, morally?
It's a controlled substance. It's a controlled substance now. Like not a Schedule 1, it's a Schedule 3, meaning it has some therapeutic benefit with some potential addiction potential. And so because of that, I have no clue. This will be interesting to see how it plays out. I'm not lying on that one.
Wow,
Yeah,
that would
so
just
that could be
major
from the dispensary
for you
standpoint.
as a pharmacist, and maybe with some regulation.
And then from a
Around
research standpoint, actually now for the first time, we'll be able to do prospective clinical trials utilizing products that are actually found in dispensaries. See, right now we have to use products that only the federal government allows. It's Schedule 3, we can actually then purchase these products from a dispensary and utilize them in evaluating of any therapeutic benefit that exists. So you're going to see suddenly a change. No more observational studies. You may start to see more robust, prospective, randomized clinical trials, which is what we really do need.
Well, let's see what happens when we do that with Shatter and see what kind of medical benefits, which are none, because no one has ever been able to.
As I said, at this point, there are no cardiovascular benefits. I can actually say that on behalf of the American Heart Association.
Well, and no mental health benefit. No one's ever been able to show how vaping is beneficial for a teen, you know, because it doesn't exist. And so maybe, you know, maybe having these studies out there, what would you say if you were
from the patient? What I'm going to tell students is that because this is a Schedule 3, I need you to have, I mean, honestly, they think, oh, it's natural, it's safe. No, I treat this like any other prescription medicine. I have that prescription medicines again, in terms of cannabis, it doesn't have, but again, a therapeutic benefit, but all medications have side effects. Some of them are nasty. And when you put it in that perspective, you're thinking this is a psychotropic agent. It's going to have side effects. It's not safe 100%. It's the same thing with supplements. I treat them the same way. So that's kind of how I will be framing this.
Okay, that's good to know. And same category as ketamine, as you know, Tylenol with codeine. I mean, obviously they know if you take too much of that, that's not going to go well for you. So I appreciate that perspective. And mostly just the gift of your time and your talent. To Johnny's Ambassadors, you are adding so much to the wealth of our database, our repository on knowledge and the impacts of THC on youth. So thank you for helping us continue to work to prevent this. And appreciate your time. We look forward to staying in touch. As you heard on those on the session, you can feel free to reach out to Dr. Page if you have follow-up questions, and we will get you your certificates. And to those watching on the recording, send us a note if you have any questions. Thank you, everyone, for being Johnny's Ambassadors. We'll talk to you later. Take care. Thanks, Robert. Take care. Bye-bye.